I'm going to introduce the next speaker, who's Leigh Reardon, who's been with us for not so long as Dr. Leigh's, but is part of our transitional clinic where our adolescents transition into adult care, our adult congenital population, which is the fastest growing population of heart disease in the country. And he provides the critical link between pediatrics and adults. Leigh Reardon on transitional care.
Thank you, Reshma. I appreciate it. Thank you for the opportunity to speak today. I'm going to be discussing transitional care, and as Reshma alluded to, I'm trained in both internal medicine and pediatrics, and then I did special training in pediatric cardiology with some additional training in adult congenital cardiology. So my appointment is both in the Department of Medicine and the Department of Pediatrics, which is a relatively unique way to participate in the care of these patients, which I really appreciate being able to bridge the gap and spend times on in both departments. I have no financial disclosures, but I do have to disclose that I come from a bias because I am myself a congenital heart disease patient. I had open heart surgery when I was 5 for pulmonary valve stenosis, which on the spectrum of congenital heart disease is on the less severe form of congenital heart disease. But fortunately, I had parents who were very interested in treating me just like my brother. They threw me on ice hockey skates about 4 months after my surgery. And they were determined to treat me just like my brother and just like my peers. In some ways, they were the ultimate transitioners because when I was a teenager, my mom, in New Mexico, where I grew up, you could get your driver's license at age 14, which might frighten most of us. My mother placed a check in a drawer right next to the kitchen counter and said, if you need to go to the doctor at any time, you don't need to tell me why. You don't need to tell me what the visit is about. Just tell me what I need to put in my check register. So she gave me an amazing amount of independence. She was interested, and my dad was interested as well, but also gave me the autonomy to transition myself and become in charge of my own healthcare. Now this morning I just came from a healthcare transitional family forum, which was over at UCLA. We had about 100 patients, families, and med-peds residents who are from the western region who are really focused on how do we transition patients from the pediatric to the adult setting. And as I'm going to show you over the next few minutes is we're really struggling to get patients from one side to the other, and we're either transitioning them too late, places like the ER, places like outside community hospitals where they don't have all the services they need. But this has become a really hot topic, and you're going to notice over time that insurance companies, CMS are going to require thorough transitional plans that show how we're going to improve outcomes by getting patients from the pediatric setting to the adult setting. This is the second conference that we've had for transitional care here at UCLA. So in the future, keep this in mind for yourselves, for your patients, and we'll try and publicize them as best as possible. There's a few quotes that I'm going to share with you throughout my slides that have come from parents and patients from this forum last year. So the first one I'm going to share with you is when we left pediatric care, it was as if someone flipped off and turned the lights off. This was from a parent who was at the transitional forum, and she just said she felt lost, like nobody was there communicating with her, that she didn't have that connection with the providers once she moved from the pediatric to the adult setting. So what is transition? So this comes from the Society for Adolescent Medicine and Health, and they define it as a purposeful, planned process that addresses the medical, psychosocial, and educational and vocational needs of adolescents and young children as they move from a pediatric world to an adult world. And in a little bit, we'll contrast how the two different departments really focus and treat patients because the approaches are very different. Now, this is not a new problem. I spoke at a conference about a year ago in Nevada with Jane Somerville, who many people will know as a very illustrious surgeon and pediatric cardiologist from London. And she, back in 1997, published this article really emphasizing the issues with congenital heart disease care. So 90% of children with congenital heart disease now will survive into adulthood. We now think in the US that 1.5 to 1.8 million people live with congenital heart disease. About 500,000 or a third of these patients have a severe form of congenital heart disease. It's growing at a rate of 5% per year. 10% of these patients will be diagnosed as adults, so for providers in the emergency department, throughout the fields of medicine, you really need to be cognizant that this is going to be a very important time to diagnose patients with congenital heart disease as well. As Dr. Alejos mentioned, we're going to have a lot of patients coming up through the ranks, and you're going to see more and more patients in the adult setting who had transplants and retransplants and who have pediatric heart failure. Just to remind you, congenital heart disease is the most common birth defect. It occurs in about 1 in every 100 to 120 births. It's 5 times more common than childhood cancer and 30 times more common than cystic fibrosis. Congenital heart disease hospitalizations in the adult setting are going to eclipse the pediatric hospitalizations for congenital heart disease. This was recently shown as an abstract at the ACC just a couple months ago, and it's shown since 1998, the percentage of hospitalizations for adults with congenital heart disease has grown by about 25.4%. That means that 42% of hospitalizations for congenital heart disease were in adults with congenital heart disease. So here's just a graphic representation of this. The popular media is finally picking up to this. You know, they really realize that this is a growing problem, and this abstract was actually featured in the Wall Street Journal. So more and more adults are going to be taking up beds. They're going to be needing advanced treatments. They're going to be needing the services of our advanced heart failure teams, and we're really going to need a multidisciplinary approach to this. So I want to tell you about a patient that's one of our favorite in the Adult Congenital Heart Disease Center who we first met just about a year ago. She was 25 years old. She has tricuspid atresia. I know Dr. Abelholsen is going to talk more specifically about specific lesions. But just to kind of point out to you, tricuspid atresia is when the tricuspid valve fails to develop and you don't have a sustainable right ventricle. She had what we call a classic RA to PA Fontan. So from the right atrium to the pulmonary artery, her blood flow was pumped up to her lungs, and she's done quite well. When she was 17 years of age, this Fontan had grown and dilated, and she had now had the nidus for arrhythmias, and she had intraatrial reentrant tachycardia, so at age 17 she underwent an ablation. Unfortunately, that was the last time she was seen by a pediatric cardiologist. She went to a college, she now works for a major international airline, and then 3 weeks prior to meeting us, she was tired and fatigued, and she was really feeling horrible, so she finally went to an emergency room, but it took her 3 weeks. This is what they found. So she was in atrial tachycardia with a 2-to-1 block. She was finally transferred to our institution. Fortunately, she was hemodynamically stable. Her heart rate was rate controlled in the 130s. Her blood pressure was fine. Her oxygen saturation was 88%, which for us congenital heart disease specialists makes us think that she's shunting from her Fontan into her right atrium and mixing her circulation. And she was on 4 liters of oxygen at that time. Her BNP was 397, and her creatinine was still normal. So we set her up for a TE and cardioversion, and we were also going to do an EP study at the same time so we could look for a tract that might be ablated again. She had anesthesia induced. We inserted the TE probe, and she had a vagal response, which we believe caused her to become bradycardic and have a PA arrest. We started CPR. We gave her epinephrine. Her pulse recovered in less than 1 minute. And she remained a little bit hypotensive, and her heart rate was okay. So I'm just going to show you some echoes here. So this is a TEE. It shows that her function was really reduced, and she had severe AV valve regurgitation. Now here's a picture of her function. It's very poor. It's probably less than 20%. And up in the top corner here, you see the swirling of blood in the Fontan, which is really profoundly reduced. And then on the upper, I guess, left-hand corner of your screen, what we found was a thrombus. She had had such poor blood flow through her Fontan that she developed a clot right there. And then at the bottom left hand of your screen, you can see blood crossing from the Fontan into the right atrium. So this is the fenestration or a shunt between her Fontan and her outside circulation. So now we're in a conundrum. She's in an arrhythmia. She has really poor function because she's been in this arrhythmia for over 3 weeks. She has a clot in her Fontan, and she has a communication to her arterial side. So I went down, I spoke to the family, I discussed sort of the conundrum we were in. I said, we have a really tough choice, and one of the choices we have to make is whether or not we cardiovert her and risk dislodging that thrombus crossing over the hole in the Fontan and her having a stroke. But unfortunately, she wasn't going to tolerate being in this rhythm very much longer. Her function was already decreased, so we decided to proceed that way with the family, full knowing that this could be a devastating event. Fortunately for her, sinus rhythm was restored with cardioversion. Her head CT was normal. She woke up. She was normal. We diuresed her. We tried to make her as optimal as possible, and we sent her home on the therapy you see there. Her ejection fraction remained low, though. But over the next year or so, her function improved. Her function's now in the mid-50s. This is an MRI we did about a week and a half ago. You can see that the flow in the fontan is still significantly reduced with the swirling of the contrast in there. So now we're considering redoing her cath. We're talking about doing what's called an extracardiac fontan revision, where we take out the old tissue, we place a Gore-Tex graft from the IVC all the way up to the pulmonary artery, and I'll let Dr. Reamson talk about that next. Now, the interesting thing is the patient is now approaching age 26, so in about a month, she falls off her parents' insurance. She's getting married in October, and she tells me that she wants to be pregnant in 1 to 2 years. So these are the types of issues that we deal with on a day-to-day basis, and unfortunately, a lot of our patients come in either pregnant, they come in straight through the ER, nobody's ever talked to them about these very important issues. So this is what transition looked like for her. So now, why are these gaps in the ladder from the pediatric to the adult world? So there's a great organization called the Adult Congenital Heart Disease Association, and I encourage you to look on the website, on the internet for their website. They have a list of adult congenital centers across the country. But they did a survey of their own patients, about 1,500 of them, and they said that about 67% of them had a gap in care of about 3 years, 38% of them had a gap in care over 10 years, and 84% of them experienced that gap between the age of 18 and 25. So we're missing an opportunity is what it comes down to. Not surprisingly, the more mild the condition you have, the more likely are you going to have a gap in your care, because you're going to be treated normal, you're going to be told you're cured potentially, and you're also not going to feel any symptoms, okay? So what we do know is that successfully transitioned patients have a higher rate of clinical follow-up, they have a better clinical alliance and adherence to their medical regimens, and it also results in better outcomes. There's fewer emergency room visits, there's fewer and lower risk interventions, there's fewer medical misadventures, and there's an improved therapeutic alliance with their practitioners. So what we need to do, both in pediatrics and internal medicine, on the cardiology side and throughout all of sort of medical care, because this applies just as much for the renal transplant and the treated AML as it does to the congenital heart disease patients, is we need to figure out a way to provide a smooth transition. And unfortunately, the setting that you're in is going to really dictate how you do that. If you're in a system like UCLA, where you have a children's hospital within a large hospital, you have the cross-pollination where maybe that type of interface is going to be much easier. But if you have a hospital clinic and another hospital clinic that are 10 miles away from each other, finding that bridge is going to be very hard to do, and you're going to have to be creative about how you approach these issues. As I mentioned before, this is really gaining traction. Transition plans are being required now by insurance companies and governmental agencies. Now, why do these transition and these gaps occur? Adolescence is a high-risk period. There's a lot of issues between parents and children that sort of foster these issues. There's a lot of insurance issues. I just came from that transitional forum, as I mentioned before, and we have a lot of exciting things that are happening with the Affordable Care Act, but it also provides a lot of confusion. Patients often believe that they're cured. Parents often take over the responsibility of health care from their children and don't allow children to develop that sort of sense of autonomy and sense of medical well-being on their own. So there's been a lot more research recently on the transition of patients from the pediatric to the adult setting. This was recently published in JACC, and it was a survey of pediatric cardiologists asking what are the perceived barriers to transition. Now, the interesting thing is that they all sort of noticed or noted either a patient or a parental attachment to the pediatric provider, and then a lack of qualified specialists was the number third reason for this. Now, these same providers said these are the major reasons why we would transition. Either they have other comorbidities that I'm not comfortable taking care of. The age of the patient is another reason. In this same study, they showed that pediatric providers were typically comfortable up until about the age of 30 to take care of their patients, and then felt after that they were getting outside of their comfort range. And then pregnancy was the number 3 reason why patients were transitioned, which many would argue that that's already too late. So this is a abstract we recently published at ACC as well, where we're participating in a multi-center trial asking patients what they understand about their own disease processes. What's interesting is that 64% of the patients that we talked to said they had never had a discussion with their pediatric provider about what they would need as an adult. So how do we bridge the gap? So pediatrics is on one side of the hill, the adult cardiologists are on the other side of the hill, and how do you get people across that bridge? Now, pediatrics tends to be relational, tends to be very much focused on developmental type issues. It tends to be family-centered communication. It tends to be a little bit more nurturing and specialty focused, because if you have congenital heart disease, often the pediatric cardiologist takes over and the family doesn't trust anybody else to even say, yes, you have an ingrown toenail. Now, on the adult side, things tend to be much more cognitive. Function tends to be static or declining. Communication tends to be more one-on-one. And it really requires a lot of autonomy, where knowledge is empowerment. And you need to go talk to your primary care physician about this, and go talk. And so it's a little bit more disjointed. At the same time, you have to meet the patient where they're at. You know, some patients are like, get me out of the pediatric setting. I'm tired of sitting on a submarine to be examined, and I want to be an adult. And then here's another parent who says, gosh, I realized after talking to you that I taught my child more about how to cross the street safely than how to take care of their own medical conditions. You know, and it was really sort of at the Transitional Care Forum last year, this was really sort of an interesting point for me, and I use it as an example every once in a while. You've taught your child how to become an adult, and now you need to teach them this component of their life. So our program really is more of a broad-ranging program. We try not to take over the cardiac care from a pediatric cardiologist or from an adult cardiologist. We're trying to develop multidisciplinary settings where patients meet their providers so that there's familiarity on both sides of the offices. There's a lot of principles of successful transition, everything from being flexible to having a structured care plan. We initiate the transition process at UCLA at the age of 12, so that patients and parents can start to understand their responsibilities, start the let and grow process, starting to be cognitive about the types of changes that we'll be having over the next several years. It needs to be future-focused, proactive, and flexible, as I mentioned, and it really needs to foster personal and medical independence. As I mentioned before, early adolescence is the period where there's a lot of concrete thinking. It's testing boundaries with parents and really testing boundaries. Again, we have to take the opportunities early to address psychosocial, sexual, substance abuse type issues. The best time to really address these issues are around age to 14 to 16, when you really have an opportunity to impact patients' directions. And then in late adolescence, you're really focused on that letting go process so that you don't hit that 18 to 25 period with a gap in care. So right now, our bridges tend to look a little bit more like this. Hopefully with some time, we'll get closer to this. And here's a group of transplant patients that we'll see in the adult setting in not too long. Thank you very much.
We can take one question real quick. Anyone have a question? We can reserve them for the end. Okay. I have a question. Will that girl be able to have a baby with all of these problems?
So, you know, we'll go through a pretty rigorous risk assessment. I think that her physiology would be best achieved by getting the extracardiac Fontan, as we mentioned, and then seeing how she tolerates that procedure and what her function is when she comes out of the procedure. When we evaluate patients, particularly with single ventricles, for the potential for having a successful low-risk pregnancy, we do a variety of things, such as a cardiopulmonary exercise test, because running on a treadmill simulates pregnancy for about 8 to 10 minutes, but not for 9 months. But ultimately, I can't substitute my values for hers. And I think the better we transition patients, the better they understand their risks, the more informed that they'll be able to be, and then they can make their own choices ultimately, and they will. Thanks.
Thanks very much.